All right, let's talk a little bit about hydrocephalus. So hydrocephalus is an imbalance either in the production of cerebrospinal fluid and absorption of cerebrospinal fluid, or a lack of being able to circulate the cerebrospinal fluid throughout the brain and spinal column. Ventricles fill up with the CSF, and then that causes intracranial pressure increases. The risk factors for the development of hydrocephalus can either be congenital or due to injury or disease. Most people think that the only way to have hydrocephalus is when you're born, that it is congenital and it's caused by either a genetic anomaly or an environmental exposure in utero. And that's not always the case. An injury or disease process that affects the ventricles themselves in the brain can happen at any time, and it can be due to either like an intraventricular hemorrhage, malformations such as a Chiari malformation. That is a very common type of intracerebral malformation that occurs and can block up the ventricles. It can also happen because of tumors growing too large and putting pressure and decreasing the absorption and elimination of the CSF, and also non-accidental trauma as well as accidental trauma. So any injury to a child or infant's skull that could cause swelling can cause blockage of the ventricles, leading to hydrocephalus. The prognosis is really dependent on the cause and the recognition of the symptoms. So some of the cues that we're going to see are irritability, lethargy, poor feeding, poor suck, vomiting, headaches, and level of consciousness changes. In our assessment of a child related to hydrocephalus, either ruling it out or monitoring it, we want to do head circumference and compare that. It can't just be, oh, this is the head circumference and every child of this age has a head circumference of this size. We all know that it's very individualized, and some babies have big, huge heads and some babies don't. And we should be looking at the trend overall. So we don't want to see a sudden increase in head circumference combined with irritability, lethargy, poor feeding, vomiting, headache, or level of consciousness changes. We are also going to look at whether or not the skull is asymmetrical, if there's a portion of it that is protruding out. And then we are also going to look at the fontanelles. If the patient has hydrocephalus or is developing hydrocephalus, we're going to see at least the anterior fontanelle become wide and potentially bulge because of the pressure that is building up. Like I said, the prognosis is very dependent on the cause of the hydrocephalus and recognizing the cues. This is some of the management that we do for hydrocephalus. There are certain times where hydrocephaly resolves on its own. We will talk a little bit more in another section about myelomeningocele and meningocele, which are a type of spina bifida. And it is frequently seen in children with those disorders that they develop hydrocephalus because of the anomaly in their spinal column. If we can fix that anomaly, then we fix the circulation of CSF through the brain and spinal cord, and we will see some hydrocephaly resolve. Children that are born with certain forms of dwarfism also have a tendency to have hydrocephaly in their early life, in the neonatal period, that also resolves. So some of the surgical management is to put in a VP shunt, which is a ventriculoperitoneal shunt. It is a shunt that goes literally from the ventricles inside the brain down into the peritoneal space, so that the excess fluid that's in the brain and around the brain can be dropped into basically the abdominal cavity and reabsorbed by the body. Frequently, children who have VP shunts do have to go through shunt revisions at various times in their life, because it can become occluded. It can, maybe the outlet could be in the wrong space, and because of growth, it no longer reaches the peritoneal cavity. And so they will potentially do revisions for that. And then it can also just completely malfunction, blockages, infection, different things, and they would have to revise it. My foster child went through VP shunt placement that was necessary because of brain damage from non-accidental trauma, and they're worried that he will likely have to have more revisions of the VP shunt than other children, because he had so much bloody fluids in the brain cavity, and it develops clots, and then it clogs up the VP shunt. So the interventions and actions that's necessary for taking care of a child who has hydrocephaly is monitoring them for increased intracranial pressure. So we're monitoring them to see what their baseline is, and then we are looking for any deviations from that. We want to maintain the current intracranial pressure that they have. If they start developing increased intracranial pressure, we need to make sure that we don't drop that pressure very quickly, because that can lead to induced cerebral edema and herniation, and then death.